Hello everyone. I am myself Dr. Rajesh Gubba. I am the General Medicine Educator. In this session, I will be discussing a very important topic, that is the abdominal aortic aneurysm. So, you need to know a very important person who had this abdominal aortic aneurysm and he had a rupture and had a death as well. So, he is none other than did you know that one of the greatest mind in the history who succumbed to this abdominal aortic aneurysm and as well as death? He is none other than the person who has said about this E is equal to mc square. That is the Albert Einstein. So on 17th April 1955, Einstein died of internal bleeding caused by the rupture of an abdominal aortic aneurysm. And Albert Einstein refused the surgery, saying, "I want to go when I want. It is tasteless to prolong the life artificially. I have done my share. It is time to go. I will do it elegantly." So these are the words what he said when he was asked to get a surgery for the ruptured abdominal aortic aneurysm. So let me discuss this topic of the abdominal aortic aneurysm in the following manner. So first I will discuss the definition, types, incidence, the risk factor, genetics, then what is the natural history, pathophysiology, classification, and what will be the clinical finding and examination in patients with abdominal aortic aneurysm, and what will be the features of the ruptured aneurysm, how to diagnose abdominal aortic aneurysm, how to screen, and what will be the management for the abdominal aortic aneurysm. So first, if you see the definition of the abdominal aortic aneurysm or the aortic aneurysm, the term aortic aneurysm refers to a pathological segment of the aortic dilatation that has propensity to expand and as well as the rupture. So what happens in case of the aortic aneurysm is a segment of aorta, right? So there will be segment of aorta which has undergone the pathological dilatation. Right, which has undergone the pathological dilatation. And this segment of aorta which has this pathological dilatation, it has propensity to expand right, it has propensity to expand and as well as the rupture. And the very important criteria to call as the aortic aneurysm is that the increase in diameter of at least 50% greater than the expected. That is what is your aortic aneurysm. So what will be the definition of aortic aneurysm is that if you take the internal diameter, right, so there will be increase in diameter greater than 50%, at least 50% greater than expected for the same aortic segment, right? And that 50% increase in the aortic segment, whatever is there, it has to be compared to an individual of same gender and as well as same age. So compared to same age and gender, if the affected part of the aortic segment is like 50% greater than the normal diameter, we call it as the aortic aneurysm. And the clinical manifestations, right, and as well as the fatality completely depends upon the size of the aneurysm, location, morphology, and what is the cause of the aneurysm. Now, particularly to tell the abdominal aortic aneurysm. What is this abdominal aortic aneurysm? So it is permanent localized dilatation of the abdominal aorta. Right, it is the permanent localized dilatation of abdominal aorta. That is what is called abdominal aortic aneurysm. And this abdominal aortic aneurysm, this disorder is conventionally diagnosed if the aortic diameter is 30 mm or more. So if the aortic diameter if it is more than or equal to 30 mm, that we call it as the abdominal aortic aneurysm. Or if the increase in the size of the vessel, if it is 1.5 times the normal diameter, then also we call it as the aortic aneurysm. So if increase in size is 1.5 times the normal diameter, this we call it as the abdominal aortic aneurysm. Now, if you see the types of aortic aneurysm, we have the two important types. One is the saccular aneurysm and the other one is the fusiform aneurysm. Now, you take this saccular aneurysm. Saccular aneurysm, it exhibits localized dilatation. Right, it exhibits localized dilatation involving only a portion of the aortic valve circumference. You can see that here. So in case of saccular aneurysm, you can observe only a portion of the aortic valve circumference is involved. So in saccular aneurysm, it is only right, it is only a portion of the aortic valve circumference. Is affected in case of the saccular aneurysm, right? And this aneurysm, right, this aneurysm, it will appear as the focal outpouching, right? It appears as the focal outpouching. That will be your saccular aneurysm. Then if you take the fusiform aneurysm, this is the more common type. Right, the fusiform aneurysm, this is the more common type. And here it is symmetrical dilatation of the aorta. Right, here it is symmetrical dilatation of the aorta, right, and there will be involvement of the entire aortic circumference. Right, involvement of entire aortic circumference. Okay, that is what is your fusiform aneurysm. So the difference is that in saccular aneurysm, it is only localized dilatation. Only a portion of the aortic wall circumference is dilated. But whereas in fusiform aneurysm, it is symmetrical dilatation of the involved aorta. Right? And which is more common in between these two? Your fusiform aneurysm, that is the most common type. Then, another important point you need to know is the difference between the true aneurysm and as well as the pseudo aneurysm. So if you take the true aneurysm is that the aortic wall is intact but dilated. So you can see that. So in true aneurysm, the aortic wall it is intact. Right, the aortic wall is intact but dilated. Right, but dilated. So here in case of true aneurysm, all layers of the aortic structures are involved. So right? All the layers of the aortic structure are involved, that is tunica intima, media, and as well as adventitia. That is what is your true aneurysm, right? So true aneurysm in that the aortic wall is intact but dilated and all layers of the aortic structure are involved. Whereas you take in case of the pseudoaneurysm. See what happens in pseudoaneurysm? The pseudoaneurysm, this is called as the false aneurysm. And this represents lesions in which bleeding has occurred through the aortic wall, right? So here, what exactly is the problem you are seeing there? There is the lesion in the aortic wall and there is rupture of the aortic wall. Right, there is rupture of the aortic wall and resulted in a contained periaortic hematoma. So this will be, right, this will be a periaortic hematoma. Right, so this is what is your pseudoaneurysm. So in case of pseudoaneurysm, what is that you will observe? It represents the lesion in which the bleeding has occurred. So what actually has happened here? Right, what actually has happened here is the bleeding has occurred through the aortic wall and resulted in a contained periaortic hematoma. And this periaortic hematoma, it is in continuity with the aortic lumen. Right, it is in continuity with the aortic lumen. So that is about your pseudoaneurysm. So in true aneurysm, the wall of the aorta is intact but it is dilated and it contains all the three layers. But in pseudoaneurysm, it is not the wall of the aorta, it is the bleeding which is present in the periaortic area. Now, what would be the cause for this pseudoaneurysm? The pseudoaneurysm may result from the trauma. Right, the pseudoaneurysm may have resulted from trauma or contained rupture of the aortic aneurysm, right? Or this pseudoaneurysm, it could be secondary to the aortic dissection, and this pseudoaneurysm, it could be secondary to a penetrating ulcer. Right, so that is what is your pseudoaneurysm. So pseudoaneurysm, it is also called the false aneurysm. Now, if you take this abdominal aortic aneurysms, where exactly are the sites of these aneurysms? 95% of these aneurysms, let me tell you, they are infrarenal. Right, 95% of these aneurysms, they are infrarenal. It is only 5% they are suprarenal. Next, what will be the fate of these aneurysms? These aneurysms, they can have the development of the infection. These aneurysms, they can undergo rupture. So once there is rupture of this aneurysm, that can lead to an extreme fatality and as well as the mortality. And there can be stasis of the blood within the aneurysm causing thrombosis, and this thrombosed blood can rupture and can shower an emboli. So there can be also the presence of the embolism. So this will be the fate of aneurysm: infection, rupture, thrombosis, and as well as the embolism. Now, if you take the incidence of the abdominal aortic aneurysm, it is more common in men rather than women, right? And it is almost like 5 times right? It is almost like 5 times it is more common in men rather than women. So the incidence of abdominal aortic aneurysm, it is strongly associated with it is strongly associated with the age of the individual, right? And so when I am telling the word it is associated with the age of the individual, most of these abdominal aortic aneurysm, they occur in those older than 60 years, right? In those individuals older than 60 years, there is increased chance of development of the abdominal aortic aneurysm. Now let me tell you who are the patient at risk of development of abdominal aortic aneurysm. Number one, already I have said, the age of individual more than 60 years, they are at increased risk of development of abdominal aortic aneurysm. And the other important thing is, it is abdominal aortic aneurysms are more common in males rather than females. And other main risk factors include the smoking history, number two, hypertension, right? Number three, family history of abdominal aortic aneurysm, right? Family history of abdominal aortic aneurysm. So these are the risk factors for the development of the abdominal aortic aneurysm. But among all these, let me tell you, the smoking. Smoking, it carries the highest risk of development of the abdominal aortic aneurysm. The other risk factors include the male gender, positive family history. In whites, it is more common than blacks, atherosclerosis, hypertension, and as well as the diabetes mellitus. But smoking, definitely it carries the highest risk of development of the abdominal aortic aneurysm. Now apart from these, the additional risk factors include the presence of the emphysema is also the risk factor for abdominal aortic aneurysm. Then hypertension, as already I have discussed, and then the hyperlipidemia. So hyperlipidemia, right, hyperlipidemia, it is the one which is responsible for the development of atherosclerosis, which can contribute for the development of the abdominal aortic aneurysm, right? And after having discussed about the risk factors, let me also tell you that there is one genetic component or the molecular genetics which can follow or which is associated with the development of the aortic aneurysms. So what are those genetic disorders that are associated with the aortic aneurysms is, these genetic disorders they include, number one, Marfan syndrome, right, Marfan syndrome. Number two, vascular type of Ehlers-Danlos syndrome. Right, vascular type of the Ehlers-Danlos syndrome. These genetic disorders, they contribute to the development of aneurysms. But in these individuals, the thoracic aneurysms, right, that is thoracic aortic aneurysms, they are more common than compared to that of compared to that of abdominal aortic aneurysms. Okay, so that is about the genetic disorders which are associated with the development of aneurysms. Then followed by that, if you take the natural history of these patients with the abdominal aortic aneurysm, see, the natural history of these aneurysms is that gradual expansion occurs over a period of years and then they eventually rupture, right? So gradual expansion, they occur over a period of years and subsequently they undergo eventual rupture. And if you take the average rate of expansion of the abdominal aortic aneurysm, so the average rate of expansion of abdominal aortic aneurysm, it ranges from 0.2 to 0.3 centimeters per year. Right, 0.2 to 0.3 centimeters per year. And some patients, they may have stable abdominal aortic aneurysm that grows slowly for years, right? That grows slowly for years. Whereas others may have the stable abdominal aortic aneurysm size for many years, right? So it all depends upon the individual risk factor. In individuals who are smokers, the chances of progression is high. But in those individuals with just a family history, they'll have stable abdominal aortic aneurysm, right? And the size will be same for many years. And sometimes there will be sudden increase within a short period of time also. So it all completely depends upon the risk factors what the individual is having. Then followed by that, although the size of the aneurysm is most important in predicting the rupture, size alone may not predict the risk of rupture. What are the other factors? Okay, so definitely it is the size which will predict the rupture. Right, it is the size which will predict the rupture, but size alone may not predict the risk of rupture. Apart from that, the wall thickness, right? Apart from that, the wall thickness and intraluminal thrombus thickness, right? Intraluminal thrombus thickness, and as well as the peak wall stress, right? The peak wall stress. All these will contribute for the risk of rupture. Right? All these will contribute to the risk of rupture. The largest aneurysms, they have the highest risk of rupture. Okay, like for example, if you see here, the largest aneurysms have the highest risk for rupture. 1 year risk for rupture estimated to be 10 to 20% for abdominal aortic aneurysm 6 to 7 centimeters in diameter. Whereas with the abdominal aortic aneurysm diameter of 7 to 8 centimeter, 1 year risk of rupture is estimated to be 20 to 40%. And for those aneurysms larger than 8 centimeters, the chance of rupture is around 30 to 50%. Right? 1 year risk for rupture is around 30 to 50% for abdominal aortic aneurysms greater than 8 centimeters. So please remember that the largest aneurysms, they have the highest risk for rupture. But remember, it is not only the size which will determine the rupture, but also the wall thickness, the intraluminal thrombus thickness, and peak wall stress. All these will contribute to the risk of rupture. So if you see this, the 5-year risk for rupture, it is approximately 5% for abdominal aortic aneurysm of 3 to 4 centimeter in diameter. It is around 10 to 20% for abdominal aortic aneurysm for 5.5 centimeter in diameter. And for abdominal aortic aneurysms of 5.5 to 6 centimeters in diameter, the chance of rupture is around 30 to 40%. And for abdominal aortic aneurysm larger than 7 centimeters, right, the risk of rupture is almost 80%. That is around 5-year risk for rupture. Okay, so it all depends upon the size of the abdominal aortic aneurysm. Now, Coming to the pathophysiology of abdominal aortic aneurysm. So you need to know the pathological changes that will occur in the aortic wall. So the pathological changes that occurs in the aortic wall include, number one, the inflammatory processes. Right? That occurs within the aortic wall will contribute to the development of aortic aneurysm. And these inflammatory process, it will cause the breakdown of the elastic elements in the media and adventitial collagen. So this inflammatory process will cause the breakdown of the elastic elements in media and adventitial. Right? And followed by that, decrease in the tensile strength of the aortic valve. Right? And lastly, all these changes will lead to expansion of the aortic wall. Right? So these are all the pathological changes in the aortic wall that will contribute to the development of the abdominal aortic aneurysm. So let me tell you the pathogenesis. Within the tunica media, there will be infiltration of the inflammatory cells. Right? They enter into the tunica media. And these particular inflammatory cells, they create a hemodynamic stress, ischemia, autoimmune process. So basically, secondary to this autoimmune process also, the inflammatory cells, they get infiltrated into the media, and these inflammatory cells, they will release certain enzymes, and these are nothing but matrix degrading enzymes. These matrix degrading enzymes, they will cause the degeneration of the tunica media. Right? They will cause the degeneration of the tunica media. And once there is degeneration of the tunica media, the aortic wall, it becomes weak. And this aortic wall which has become weak will undergo dilatation and then rupture finally. So that is about the pathogenesis. So secondary to either your autoimmune process or hemodynamic stress, whatever it is, the inflammatory cells, they get infiltrated into the tunica media. They will release the matrix degrading enzymes, and they will cause the degeneration of the tunica media, and that will cause the dilatation and finally rupture of the aortic wall. Now, you take the inflammatory mediators. The inflammatory mediators include the pro-inflammatory cytokines, right? They include pro-inflammatory cytokines, and these pro-inflammatory cytokines such as the tumor necrosis factor alpha, that is TNF alpha. Next, interleukin 1 beta, interleukin 6, then the interferon gamma. All these will play an important role in the development of the abdominal aortic aneurysm. So all these, what do they cause? They cause the destruction of elastin right? They cause the destruction of elastin within the tunica media, right? And thereby there will be marked decrease in the concentration of the elastin, and because of marked decrease in the concentration of the elastin, the consistency of the aortic valve is reduced. Thereby there will be abdominal aortic aneurysm formation. So this will be the pathogenesis for the development of abdominal aortic aneurysm. Now the point is, why is early diagnosis of abdominal aortic aneurysm is so important? See, the operative mortality of treating a ruptured aneurysm is 80%. Right? If there is a ruptured aneurysm, and if you want to operate a ruptured aneurysm, the mortality, right, the mortality is around 80%. Okay, but you take elective abdominal aortic aneurysm cases, right, if you take elective abdominal aortic aneurysm cases, here the operative mortality rate is reduced. Right, the operative mortality rate is reduced. And you know how much it is approximately? Approximately it is only 2 to 7%. Right, the operative mortality rate for elective abdominal aortic aneurysm cases, it is only 2 to 7% of cases. They will result in the death. But whereas for ruptured aneurysm, if you want to do an operation, the chances of mortality in that cases is 80%. So this abdominal aortic aneurysm rupture can be avoided by identifying the population at risk and conducting simple and inexpensive ultrasound examination. So why is it so important? Because the risk of rupture will be reduced, mortality can be reduced. So how do you want to diagnose, or how do you want to monitor, or how do you want to identify? That is by a simple, inexpensive ultrasonographic examination. Okay, so that is the reason why early diagnosis of abdominal aortic aneurysm is so important. So for suppose, if the abdominal aortic aneurysm is not treated, what is the chance of rupture? Just now we have discussed already, right? So 5-year risk of rupture is around 25% if the size of the aneurysm is 5 to 5.9 centimeters. The chance of rupture is almost 35% if the aneurysm is size is 6 to 7 centimeters. The chance of rupture is almost like 75% if the aneurysm size is more than 7 centimeters. Okay. So the risk of rupture obviously increases as the size of the aneurysm increases. Now, if you see the classification of the abdominal aortic aneurysm, so we have what is called TAAA classification. Now, according to this classification, we have the following 5 subtypes. That is, if you take 1, right, if you take 1, here the aneurysm is below the left subclavian artery and above the renal artery. So you can see that here, this is the renal artery and this is the left subclavian artery. So here the aneurysm is below left subclavian artery and above the renal artery. Right, that will be 1. And if you take 2, it is the aneurysm which is present below the left subclavian artery and including infrarenal aorta up to the level of the bifurcation. Right, up to the level of the bifurcation. So it is below left subclavian artery and including right, and including infrarenal aorta up to the bifurcation. Right, so that will be your 2 according to your TAAA classification, which is nothing but Crawford classification. Whereas 3, it includes 6th intercostal space to the bifurcation. So you can see that here, 6th intercostal space up to the level of the bifurcation. Right, 6th intercostal space to the bifurcation will be TAAA classification. Whereas you take 4. 4 will be 12th intercostal space to the bifurcation. So you can see that here 4 will be 12th intercostal space up to the level of bifurcation. And if you take 5, 5 will be 6th intercostal space to above renal artery. Right, 6th intercostal space to above renal artery. So that will be your type 5. So type 1 is below left subclavian artery to above renal artery. 2 is the continuation of 1 up to the level of bifurcation. 3 is 6th intercostal space to bifurcation. 4 is 12th intercostal space to bifurcation. 5 is 6th intercostal space to above renal artery. So this is your Crawford classification of the abdominal aortic aneurysm. Now, what will be the clinical presentation of these patients with the abdominal aortic aneurysm? Almost like 70 to 75% of individual, they remain asymptomatic. So, majority of these patients, they are asymptomatic. But in those individuals who have the symptoms, right, in those individuals who have the symptoms, they have the symptoms like the abdominal and as well as the back pain. Right, symptoms like abdominal and as well as the back pain. And apart from these, they also have the vague symptoms like nausea and vomiting. Right, vague symptoms like nausea and as well as vomiting. And there can be abrupt onset of pain when there is rupture of aneurysm. So, whenever there is rupture of aneurysm, there can be abrupt onset of pain. Right, so these will be the symptoms of the abdominal aortic aneurysm. Now, followed by that, what will be the classical triad of manifestations? The classical triad of manifestations, they include sudden onset mid-abdominal pain or flank pain, right, sudden onset mid-abdominal pain or the flank pain. Then second important feature is the individual may land up in shock, that is whenever there is rupture of aortic aneurysm. And when you palpate this abdominal aortic aneurysm, you will feel the presence of the pulsatile abdominal mass. Right, the presence of pulsatile abdominal mass. So this will be the classic triad of the abdominal aortic aneurysm. Then, in case of the ruptured aneurysms, what will be the manifestations? Right? One important feature that already I have discussed, that is the presence of back and abdominal pain, right? The presence of the back and abdominal pain. Then, because of the rupture, they also have the development of pallor, and there will be profuse sweating, that is diaphoresis, right? And there can be syncopal attack. Once there is a rupture, there will be extravasation of the fluid from the aorta, and because of which there will be fall in the blood pressure of the individual, and that will result in the syncopal attack. Right, that will result in the syncopal attack, and ultimately these individuals will land up in death. So these will be the features of the ruptured aneurysm, right? Back and abdominal pain, pallor, diaphoresis, syncopal attack, and death. Then, if you see the fate of the ruptured abdominal aortic aneurysms, see, approximately 30 to 50% of patients with ruptured abdominal aortic aneurysm, they die before hospitalization. Okay, so right, 30 to 50% of individuals, they die before the hospitalization, and an additional 30 to 40% they die after reaching a hospital but before the treatment. Okay, 30 to 40% they die after reaching the hospital but before starting the treatment, right? And in case of these ruptured aortic aneurysms, the operative mortality rate for open surgical repair, it is up to 40 to 50%. Okay, the operative mortality rate right, the operative mortality rate for the open surgical repair, right, for open surgical repair, it is around 40 to 50%, right? And the other important point is depending upon the hemodynamic stability also. Hemodynamically stable patients with symptomatic but apparently unruptured abdominal aortic aneurysms, they should undergo CT to determine whether the rupture has occurred or not. Okay, so this will be the fate of the ruptured abdominal aortic aneurysm. So patients with ruptured abdominal aortic aneurysm, the chance of mortality is very, very high. And in those individuals who are hemodynamically stable, unruptured abdominal aortic aneurysm, they should undergo CT to determine whether the rupture has occurred or not. Then, coming to the physical examination in these patients with the abdominal aortic aneurysm, abdominal palpation may reveal pulsatile, epigastric, or periumbilical mass. So, when you palpate the abdomen, right, when you palpate the abdomen, this will reveal pulsatile, epigastric, or right, pulsatile, epigastric, or the periumbilical mass. And this pulsatile, epigastric, or periumbilical mass, it is particularly in thin patients with large aneurysm. Right, in thin patients with large aneurysm, when you palpate, you will feel for this pulsatile epigastric or periumbilical mass. And almost 30 to 40% of abdominal aortic aneurysm are noted on physical examination. Right, 30 to 40% they are noted on physical examination. And see, more than 85%, right, when you are evaluating for abdominal aortic aneurysm in patients with other vascular diseases, it is very important. That is, more than 85% of patients with femoral artery aneurysms, they have the chance of the abdominal aortic aneurysm. And more than 60% of patients with popliteal artery aneurysm, they have the chance of development of the abdominal aortic aneurysm. So, on physical examination, you will feel for the pulsatile epigastric or periumbilical mass. That is particularly in thin patients with large aneurysms. And 30 to 40% of abdominal aortic aneurysms are noted on physical examination itself. And these abdominal aortic aneurysms, they are associated with other vascular diseases like femoral artery aneurysms and the popliteal artery aneurysms. Then how do you diagnose the abdominal aortic aneurysm? See, ultrasound scan has proven to be a reliable and cost-effective way to diagnose the abdominal aortic aneurysm, right? So that is the ultrasound scan. Right, the ultrasound scan has proven to be reliable and cost-effective way to diagnose the abdominal aortic aneurysms, right? And this abdominal aortic aneurysm, this an ultrasound scan, it is an extremely sensitive test for all abdominal aortic aneurysm sizes. So, this is extremely sensitive investigation or sensitive test, and this is painless and non-invasive. Right, painless and non-invasive, and it is also one of the cost-effective investigation, right? And the other methods of investigating this abdominal aortic aneurysm is computed tomography, that is CT scan, next MRI, that is magnetic resonance imaging, and as well as magnetic resonance iotography. So if you take this ultrasound already I have said you, it can detect the abdominal aortic aneurysm with high accuracy and sensitivity. And if you take the sensitivity and specificity, the sensitivity and specificity of abdominal aortic aneurysm is almost like 100%. Right, it is almost like 100%. Okay. And this abdominal ultrasound, it is more preferred over the CT scan in screening of the abdominal aortic aneurysm. And the advantage of abdominal ultrasound is serial measurement of the abdominal aortic aneurysm size. Right, the serial measurement of the abdominal aortic aneurysm size. Okay. So even for the follow-up, this ultrasound is very, very important. Okay. Next, then followed by that, the CT scan. Abdominal CT, it is extremely accurate in both detection of abdominal aortic aneurysm and measurement of the aneurysm diameter. Okay. For the detection of abdominal aortic aneurysm, and it is also very much important for the measurement of aneurysm diameter. Okay, so this is the importance of the abdominal CT, right? And this CT scan, when you combine with radiographic contrast enhancement, you will also have the three-dimensional reconstruction imaging, right? When this CT scan, when it is combined with radiographic right, when you combine CT scan with radiographic contrast enhancement, then you will have the 3D constructional image. Right, 3D reconstruction image. Okay, and let me tell you, if you take the accuracy wise, the CT angiography, right, CT angiography, this is more accurate than compared to that of the ultrasonography. And the CT angiography is especially useful in demonstrating the extent of the aneurysmal disease. Right, so it will also tell you about the right, this will also tell you about the extent of the aneurysmal disease. And the CT angiography, the relationship of the abdominal aortic aneurysm to the renal, visceral and iliac arteries, and what is the pattern of the thrombus. See, with the help of CT angiography, you will be able to make out everything, that is extent of the aneurysm size, right? You will be also able to make out if there is any associated vessel aneurysm. You will be also able to make out if there is any thrombus calcification and if there is any occlusive atherosclerosis. All these can be made out by your CT angiography. So let me tell you, your CT angiography, it is more accurate than compared to that of the ultrasound. So I said you, with the help of CT angiography, by using the contrast, you will be also able to make out the reconstruction images. 3-dimensional reconstruction images can be made out. Okay. Now, followed by that, the another important group of, the other investigations are the magnetic resonance angiography. See, even this also have high accuracy in detecting the abdominal aortic aneurysm, right? So, with the help of magnetic resonance angiography, you will be able to make out the aneurysm diameter. Right, you will be able to make out what is the aneurysm diameter, and it also helps in planning the treatment. Okay, and the advantage of magnetic resonance angiography is it avoids exposure to radiation. Right, it avoids exposure to radiation, and it also avoids iodine based contrast material. Right, it also avoids the iodine based contrast being used. Okay, and if you take the imaging modality, CT is preferred imaging modality. However, for evaluation of the abdominal aortic aneurysm in most institutions, right? See, MRI, definitely yes, it is also the best investigative procedure, but that can be done only in a stable individual. And mainly when you are taking the individual to any intervention, that is the point where the MRA, that is magnetic resonance angiography, will be more useful. And for the screening purposes, right, for the screening of abdominal aortic aneurysm, ultrasonography is very much useful, right? And by doing the screening, there is reduced abdominal aortic aneurysm related deaths. Right, by doing an ultrasonography, there will be reduced abdominal aortic aneurysm related deaths. Okay, that is the advantage of the screening, right? And if you take the overall incidence of screening detected abdominal aortic aneurysm, screening detected abdominal aortic aneurysms, they range from 1 per 1000 in adult younger than 60 years to 7 per 1000 in those in their mid 60s. So the chance of aneurysm increases as the age of the individual increases. Not only the age, even if you take the other risk factors like male gender, smoker, family history, history of other aneurysms, hypertension, atherosclerotic disease, and hypercholesteremia. In all these scenarios, let me tell you, the chance of aneurysm is very high. Okay, so screening for abdominal aortic aneurysm with ultrasound, it will reduce the abdominal aortic aneurysm related death of the individual, right? Next, followed by that, aneurysm screening is associated with 50% reduction in rupture and 50% decrease in aneurysm related mortality, right? 50% reduction in rupture and 50% decrease in aneurysm related mortality. Then followed by that, if you take the management, so we have the medical therapy and as well as the surgical therapy. In those individuals with small abdominal aortic aneurysms, they can be observed safely with imaging surveillance and little risk of rupture. Okay, so in those individuals with small abdominal aortic aneurysm, they have to be just observed, right? Surgical intervention is not required. Okay, and in them the risk of rupture is also less. Right, and in which type of aneurysms, right, or what should be the size of the aneurysms for the surgical intervention? See, abdominal aortic aneurysm repair, it is reserved for asymptomatic aneurysm at least 5 to 5.5 centimeters in diameter. Okay, so abdominal aortic aneurysm repair, right, this is reserved in individuals right, in individuals who are asymptomatic and the size of the aneurysm is 5 to 5.5 centimeters in diameter. Right, so in these individuals the surgical repair is required. Now let me also tell you some of the very important guidelines according to the Society of Vascular Surgery guidelines. Okay, what is the criteria for surgical repair? What is the criteria for medical therapy according to these guidelines? Let me discuss now. So now let me tell you the treatment strategies according to the Society of the Vascular Surgery guidelines. So in case of the asymptomatic aneurysm, what did I tell you? In case of asymptomatic aneurysm, at least of size of 5 to 5.5 centimeters in diameter, those aneurysms, they require the abdominal, they require the repair. Okay, whereas in case of the symptomatic aneurysms, right, symptomatic aneurysms and those aneurysms with rapid growth in the sense more than 1 centimeter per year, they require vascular surgical consultation. Okay, so symptomatic aneurysms, so symptomatic aneurysms in the sense the abdominal pain or presence of nausea and vomiting, and as well as those aneurysms with rapid growth. Okay, so rapid growth in the sense more than 1 centimeter per year. These aneurysms, they require vascular surgical consultation. Then followed by that, the second important thing is In patients with abdominal aortic aneurysms larger than 4.5 centimeters, let me tell you, CT scan is preferred over the ultrasound for more accurate measurement of the abdominal aortic aneurysm size, right? So, abdominal aortic aneurysms of size 4.5 centimeters, right? For these aneurysms, CT scan is more preferred than compared to that of the ultrasonography, right? That is mainly to make out the accurate measurement of right, to make out the accurate measurement of the size of the aneurysm. Next, followed by that, the surveillance of the aneurysm until the diameter exceeds 5.5 centimeters, it is associated with a low risk of or low rate of the rupture. So aneurysms of diameter 5.5 centimeters, they require the close surveillance because they have the risk of rupture. Then followed by that, the Society of the Vascular Surgery guidelines suggest the following surveillance strategy for abdominal aortic aneurysms of various size. So, like for example, if the size of the aneurysm, if it is around 2.6 centimeters to 2.9 centimeters, these aneurysms, they require imaging every 5 years. Whereas the aneurysms of the size 3 centimeters to 3.4 centimeters, these aneurysms, they require surveillance every 3 years. They require the monitoring by either ultrasound or CT scan every 3 years. Whereas the aneurysms of the size 3.5 to 3.9 centimeters, they require the surveillance or imaging at every 12 months. That means every year. Whereas the aneurysm of the size 4.5 to 5.4 centimeters, they require imaging every 6 months. Right? They require imaging every 6 months. Okay, right. So this is about how close the surveillance has to be done depending upon the size of the aneurysm. And uncertainty exists regarding the ultimate therapy for the abdominal aortic aneurysm between 4.5 and 5.4 centimeters. Okay, so what you have to do between the size of 4.5 to 5.4 centimeters, it is completely individualized, right? The recommendations must be completely individualized. Okay, whereas a young healthy patients, especially women with abdominal aortic aneurysm between 5 to 5.4 centimeters, right? So I repeat this point, young healthy patients, especially women, right? Especially women with abdominal aortic aneurysms between 5 and 5.4 centimeters, they benefit from the early repair. Right, they benefit from the early repair and this will avoid the rupture as well. So this is about the surveillance that has to be done depending upon the size of the aneurysm. Next, coming to the steps which have been recommended for patients with abdominal aortic aneurysm. Coming to the steps that have been recommended for patients with abdominal aortic aneurysm to minimize the risk of expansion of aneurysm and improve the overall health. What are those steps? First and foremost, the smoking cessation. Smoking cessation is important in as much as strong evidence has linked ongoing tobacco use with more rapid rates of the abdominal aortic aneurysm expansion and even rupture. Okay, so smoking cessation is very important. Right, smoking cessation, it is very important, right? And because the tobacco use has been found to be with more rapid rates of the abdominal aortic aneurysm expansion and as well as the rupture. Next, the other important thing is the use of statin. Right, the statin use can be recommended for almost all patients with abdominal aortic aneurysm based on the presence of the coexisting atherosclerotic disease. Okay, so the statin use, it is also found to be, even this particular drug is found to reduce the expansion of the aneurysm, because in majority of the individual there will be presence of the coexisting atherosclerotic disease. Okay, and another important group of drugs is the AC inhibitors. Right, so AC inhibitors, they also have been found to show a minimal benefit in reducing the rate of expansion of the abdominal aortic aneurysm. But as such, there is no available data, but in some of the individuals, these drugs have been found to benefit the patient by reducing the rate of the expansion of the abdominal aortic aneurysm, right? And patients with small abdominal aortic aneurysms should be encouraged to exercise regularly, because moderate physical activity does not adversely influence the risk of rupture, and this may even limit the rate of the abdominal aortic aneurysm growth. So small abdominal aortic aneurysms, those patients, they can undergo moderate physical activity, right? That will not cause any rupture, that even will limit the rate of the abdominal aortic aneurysm growth. And apart from that, we have some experimental drugs. Okay, that is, if you take the pharmacotherapies, there are certain drugs that will suppress the growth rate of the small abdominal aortic aneurysm, and these particular drugs, they will reduce the need for surgical repair. That is of great interest. Now, what are those group of drugs? Let me discuss. See, one of the earliest approaches suggested was the use of the beta blockers. Right, the use of the beta blockers. See, these beta blockers, they will diminish the hemodynamic stress. Right, they will diminish the hemodynamic stress, and thereby they will reduce the rate of growth of the abdominal aortic aneurysm, right? So that is about one of the experimental drug. Now, apart from that, we have few more drugs like doxycycline. So what is the role of doxycycline? Let me explain you. Doxycycline, it is a tetracycline. See, treatment with doxycycline has suppressed or prevented the abdominal aortic aneurysms, particularly in animal models in association with MMP inhibition. Okay, so this has been found to reduce rate of growth of abdominal aortic aneurysm, right? And this particular doxycycline, it is mainly used in animal models in association with matrix metalloproteinase inhibition, right? MMP inhibition, that is matrix metalloproteinase inhibition. So what this doxycycline will do is, doxycycline will decrease the MMP activity. Right, doxycycline will decrease the MMP activity in aneurysmal aortic tissue and in the circulation as well. So once it reduces the MMP activity, the growth of the aneurysm will get reduced. So that is about the usage of the doxycycline. So one drug was your beta blockers, which will reduce the hemodynamic stress, and doxycycline is the drug which will decrease the MMP activity in aneurysmal aortic tissue. Then next, followed by that, the third experimental approach is the use of the AC inhibitors or the angiotensin receptor blockers. So the AC inhibitors, or the angiotensin receptor blockers. What are the examples of angiotensin receptor blockers? Such as losartan. What they will do is they will modify the metabolism of connective tissue in the aortic wall, right? So once they modify the metabolism of connective tissue in the aortic wall, they can reduce the rate of growth of the abdominal aortic aneurysm, right? They can reduce the rate of growth of the abdominal aortic aneurysm. So that is about the treatment strategies. So one important group of drugs is your beta blockers, then followed by that the statins, then we have the ACE inhibitors or angiotensin receptor blockers, and then doxycycline. So all these drugs have been used mainly to reduce the rate of growth of the abdominal aortic aneurysm. Next, coming to the surgical repair. So we have two important options for surgical repair. One is the open surgery and the other one is EVAR, that is endovascular repair, right? That is endovascular stent grafting. Now let me tell you what are the advantages and disadvantages of the open surgical repair and as well as advantages and disadvantages of the endovascular stent grafting. So if you take the advantages of the open surgical repair, see, in case of open surgical repair, the aneurysm can be easily opened, right? And if there is any atherosclerotic plaque, that can be removed and we can put a graft. Okay, so the graft is, this is a graft, right? So the graft is sewn in and the aorta wrapped and closed around the graft. That is what you can do in case of the open surgical repair, right? And this is one of the established procedure. And this will prevent the growth of the sac. Open surgical repair, it will prevent the growth of the sac. And it has this open surgical repair with graft, it has a proven long-term results. Okay, so the outcome of the individual is good. But then what are the drawbacks with this open surgical repair? See, with the open surgical repair, a long incision over the abdomen has to be given. So a significant incision is given in the abdomen. Okay, and you need to clamp the vessel for nearly around 30 to 90 minutes. So there may be chance of ischemia to the organs distal to that particular clamp. And it is little time taking procedure, nearly around a 4-hour procedure. And it is contraindicated in some patients who have the high surgical risk. So in patients with high surgical risk, you cannot do the open surgical repair. And these patients, they are morbid, right? Morbidity will be there for a long duration of time. So 1 to 2 days in the intensive care, they have to be there, 5 to 7 days of hospitalization and 4 to 6 weeks of recovery time. So in case of open surgical repair, for the individual to come back to the routine life, it will take nearly around 1.5 to 2 months. But the same is not in case of the endovascular grafting. Okay, so these are some of the drawbacks of the open surgical repair. And some more drawbacks of open surgical repair is that in high risk patients, you cannot do this particular open surgical repair. So many patients, they are considered unfit. Why? Either because of the anesthesia risk, right? Or because of the significant comorbidities, or because of the previous abdominal surgeries or the hostile abdomen. So because of these, many of the patients, they are considered to be unfit for the open surgical repair, right? And not only that, the recovery. Okay, so the recovery also, it is a difficult recovery for the patient. So these patients, they lose the independence, right? So they are completely dependent on a caretaker for the time until the individual has come back to the normal routine life. And these patients, they have a very high perioperative morbidity, and there is 5% risk of the mortality. Okay, so these are the drawbacks of the open surgical repair, right? So what are the advantages? The advantages is that the aneurysm can be opened, graft is sewn in, and the aorta is wrapped and closed around the aortic graft. And it is an established procedure and it gives a very good result. Long-term result is good. But the drawbacks is the perioperative morbidity is very high. Okay. Next, then coming to the endovascular stent grafting. See, the advantage of the endovascular stent grafting is that this is minimally invasive. See, in case of open surgical repair, you need to give a significant incision over the abdomen. But whereas this procedure, like endovascular stent grafting, it is minimally invasive and there is reduced risk of death. So in case of your open surgical repair, there is increased morbidity and increased mortality as well. And this endovascular stent grafting, they have faster recovery. But there, in case of open surgical repair, it will take nearly around 1.5 to 2 months for an individual to return back to the normal routine life. Okay, and these individuals, they also have improved functional outcomes. So this will be the benefits of the endovascular stent grafting. Then what will be the drawbacks? See, the drawbacks of the endovascular stent grafting is that the chances of the leakage. So endo leaks are very common, and for this re-intervention is required again. And there is chance of the stent graft migration. The stent what you have placed, there is chance of that stent to be migrated to a distant place, right? And there can be a modular dislocation of that particular stent graft what you have put, right? And most complications, they are benign and they are treatable by endovascular techniques, right? They are treatable by endovascular techniques. And new stent graft generations, they are associated with a few complications, right? New stent graft generations, they are associated with few complications. So this is about your endovascular stent grafting drawbacks. So mainly we are very much concerned about the complications like endo leaks, stent graft migration and modular dislocation. But all these complications, they are benign and they are treatable by the endovascular techniques. Now, and in case of the endovascular stent grafting, you need to make out the morphology suitable for the endovascular repair. That is, these patients, they require adequate vascular access and they should have an appropriate landing zone, right? You cannot keep the stent in an abnormal area of the aneurysm, right? This stent, it has to cover the aneurysmal dilatation along with the normal area of the aorta. Also, the stent has to be placed. So adequate vascular access and appropriate landing zones are required. And coming to the tortuosity, calcification and as well as the thrombus formation. So these are some of the limitations for the endovascular stent grafting, right? And they require precise sizing of the stent also, right? For which you need to take the CT scan slides of nearly around 3 mm thickness. Thereby you will be able to make out what should be the exact size of the stent you have to place. Okay, so good imaging equipment in the lab or in the operating room is very much required. So these are, certain requirements for the endovascular stent grafting. Adequate vascular access is required, appropriate landing zone is required, and then if there is any tortuosity, calcification or thrombus, that will be limitations for your endovascular repair. And in order to precisely size the stent size, the CT scan slides should be of 3 mm. With that, you will be able to make out where exactly you need to put the stent. So good imaging equipment in the lab or in the operating room is very much required. Okay. Then, now the decision to undergo elective repair in case of the asymptomatic abdominal aortic aneurysm, right? So this is about your surgical interventions, open surgical repair and as well as endovascular grafting. Now coming to the decision to undergo elective repair in an asymptomatic individual completely depends upon the life expectancy of the individual. So what I am about to tell you now is, in asymptomatic individual, which particular asymptomatic individual has to undergo the elective repair. So the decision to undergo elective repair of an asymptomatic abdominal aortic aneurysm completely depends upon the life expectancy of the individual and the estimated risk of rupture balanced against the estimated risk associated with abdominal aortic aneurysm repair. So, please remember, in case of asymptomatic abdominal aortic aneurysm, whether to undergo elective repair or not completely depends upon the life expectancy of the individual and as well as the risk of rupture. Now, what are the factors that will influence the operative morbidity and as well as mortality? See, if the individual is having associated coronary artery disease, right? If the individual is having associated coronary artery disease, chronic kidney disease, COPD, diabetic patients, these individuals definitely have a high operative morbidity and as well as mortality. But whether to get operated or not completely depends upon the risk of rupture of the individual. And I said you, the increased age, increased size of the aneurysm, risk factors like smoking, family history, these individuals, they have the high risk of the rupture. So please remember, it is not only the size which will tell you the risk of rupture, and associated risk factors like smoking also tells you whether the individual is at risk of rupture or not. So this is about the abdominal aortic aneurysms and what is the various ways you can manage these particular patients. So this abdominal aortic aneurysms, they are of morphologically two types. One is saccular and the other one is the fusiform, right? And very important risk factor is the smoking. So smoking cessation is very important as a treatment strategy. Now let me discuss some clinical scenarios of the abdominal aortic aneurysm and let me discuss some questions as well. That is, so if you see the first question, a 68-year-old woman presents to your office for a routine follow-up visit. She has no complaints. Her medical history is notable for type 2 diabetes mellitus and hypertension. She has 60-year history of the cigarette smoking. The physical examination is notable for a 4 to 6 centimeters pulsatile non-tender abdominal mass. The patient denies having abdominal pain and she has no family history of abdominal aortic aneurysm. Which of the following is the best step to take next in the workup of this particular patient? So, routine follow-up visit, asymptomatic 68-year-old women, and risk factors are type 2 diabetic and as well as hypertensive and as well as smoker. But when you have examined, you have found that there is pulsatile non-tender abdominal mass which is of size 4 to 6 centimeters, right? And no abdominal pain, no family history of aneurysms. What is the next thing you have to do? The patient should return every 3 months for serial physical examination to follow the suspected aneurysm. The patient should be immediately referred for the surgical evaluation. An abdominal ultrasound should be ordered to evaluate the possible aneurysm. No further intervention is necessary. So, this particular patient requires an abdominal ultrasound should be ordered to evaluate the possible aneurysm. See, when you have palpated, you found that pulsatile mass, but it is not confirmatory that it is abdominal aortic aneurysm. So, first of all, you need to do an ultrasound to look for if there is any possible aneurysm. Okay, so early recognition of abdominal aortic aneurysm, it is always life-saving, right? It is always life-saving. So for that reason, these patients require an ultrasound to look for the possible abdominal aortic aneurysm, right? And most of these abdominal aortic aneurysm, they are asymptomatic. That is what I have discussed in the clinical features also. Almost like 65 to 70% of individuals, they are asymptomatic and they are discovered during routine physical examination or as a result of non-invasive screening, right? And these individuals, they are the aneurysms, they have risk of expansion, they have risk of rupture. So the periods of rapid expansion or impending rupture are often marked by severe discomfort in the lower abdomen or back. So when there is chance of impending rupture or during the periods of rapid expansion, there is severe discomfort in the lower abdomen or back, and the pain may radiate to the buttocks, groin or the legs. And these patients with impending or actual rupture must be managed as a surgical emergency. So in those individuals who had a rupture, they have to be managed as a surgical emergency in a manner similar to that of patients with major trauma, right? And the fact that this patient is completely asymptomatic makes simple aortic imaging a more reasonable first step than the urgent surgical referral. Okay, so this will be the explanation. So you see here, no further intervention is necessary is a wrong statement, because there is a pulsatile mass. You have to know what exactly is that. Okay, and immediately referred for surgical evaluation? No. The individual is asymptomatic. Urgent referral for surgical evaluation is not required until unless you don't know what exactly is that. Return every 3 months. See, the surveillance, following up of the aneurysm completely depends upon the size of the aneurysm. That already I have discussed in the guidelines part. Okay, next, you see the next important question. Yeah, and if you see now, the recommendations, the current recommendations are for non-invasive screening of patients of appropriate age, which is typically defined as older than 65 years. Our patient is of the age of 68 years. So individual more than 65 years, they require a non-invasive screening. And abdominal ultrasonography, that is the most frequently used and most practical method. And this ultrasonography, it has a high sensitivity of nearly around 100% for diagnostic aneurysm. Right? They have the high sensitivity. Okay? And assessment by physical examination alone is unreliable. Right? By physical examination alone is unreliable. Therefore, an imaging study is needed to confirm the diagnosis of the aortic aneurysm and, if present, to determine the size of the aneurysm. So, and any aneurysm larger than 6 centimeters in diameter, they are generally referred for surgery, and those aneurysms less than 4 centimeter in diameter, they are generally watched. So this is about like the follow-up of the abdominal aortic aneurysm. Right. Coming to the next important clinical scenario. A 62-year-old man with long-standing hypertension presents to your office for evaluation of the non-productive cough. He has had the cough for 2 to 3 months and is getting progressively worse, and he is without other complaints. So hypertensive, dry cough. And the patient blood pressure is 168 by 94 millimeters of mercury, and other vital signs are unremarkable. A chest X-ray reveals a widening of the mediastinum. The spiral CT scan reveals the thoracic aortic aneurysm with impingement upon the trachea. Which of the following statements regarding the thoracic aortic aneurysm is true? First option, the aneurysms that are invading the local structure should usually be resected. What is given here? With impingement upon the trachea. So first option is resection. Second option, in contrast to abdominal aortic aneurysm, the size of the thoracic aortic aneurysm is not a critical issue in terms of risk of rupture. Third option, in contrast to abdominal aortic aneurysm, careful control of blood pressure is not a crucial issue for patients with the thoracic aortic aneurysms. Fourth option, most thoracic centers recommend surgery for thoracic aortic aneurysms that exceed 7 cm in otherwise suitable surgical candidates. Right? Now, what is the correct answer in this individual is aneurysms that are invading the local structures, they should be usually resected. That is the true statement. Okay. Now, let me discuss few points about the thoracic aortic aneurysm. Look, what is the last option? Most thoracic centers recommend surgery for thoracic aneurysms that exceed 7 cm in otherwise suitable surgical candidates. Let me discuss about the thoracic aortic aneurysm. See, this patient has a cough, right? And why do you think this particular patient is having a productive cough? That is because of the impingement by the thoracic aortic aneurysm on his trachea. Right? There is impingement by the thoracic aortic aneurysm on his trachea. And that is the reason why the individual is having a non-productive cough. The fact that his cough is a new problem likely reflects the expansion of the aneurysm. The aneurysm is increasing in its size. And aneurysms that are invading the local structures, or aneurysms that are creating a marked vascular effect, they should usually be resected. Right? Any aneurysm invading the local structures, they have to be resected. And the size is a critical issue in terms of risk of rupture. The initial size the potential growth of the aneurysm, they are the important factors in decision whether to operate on the asymptomatic aneurysms. So, size is a very important factor, a critical issue in terms of risk of rupture. More is the size, increased risk of rupture. And careful control of blood pressure is crucial for all patients, and they may require the medical therapy. So careful control of blood pressure is crucial for all patients and may require the medical therapy, particularly with beta blockers. Right? These beta blockers, what they will do, they will slow the rate of the aneurysm growth. Right? They will slow the rate of the aneurysm growth. And currently, most thoracic centers recommend surgery for aneurysms that exceeds 5.5 to 6 centimeters in an otherwise suitable surgical candidate. It is not 7 centimeters what is given in our option. So, you take the last option. 7 centimeters is given. No, it is not a true statement. So, when the size of the aneurysm is around 5.5 to 6 centimeters and the individual is a suitable surgical candidate, they have to undergo surgery. Right? So, it's a wrong statement. And abdominal aortic aneurysm, careful control of blood pressure is not a crucial issue, wrong statement. Right? Careful control of blood pressure is very much important. And in contrast to abdominal aortic aneurysm, the size of thoracic aortic aneurysm is not a critical issue in terms of risk of rupture is a wrong statement. Thoracic aortic aneurysms, if they rupture, the individual may land up in cardiac tamponade, the individual may land up in pericardial effusion, right? The individual may develop pleural effusion, so that will be a highly fatal. So even the thoracic aortic aneurysms, they are also of very much important. So if you see the next clinical scenario, a 68-year-old man with long history of the cigarette smoking presents for routine evaluation. On physical examination, he has a pulsatile abdominal mass and ultrasound shows 4.5 centimeters infrarenal aortic aneurysm. He reports no symptoms of abdominal pain or back pain. What would you recommend for this particular patient? Referral for surgical repair, aortogram for further evaluation of aneurysm, repeat ultrasound in 6 to 12 months, treatment with a beta blocker. So this particular patient require the repeat ultrasound in 6 to 12 months. So why not surgical repair? Why not aortogram? Why not treatment with the beta blockers? Let me explain you. So studies have shown that the likelihood of rupture is highest in patients with symptomatic or large aneurysm. Our patient is asymptomatic, right? So please remember, in symptomatic aneurysms and as well as large aneurysms, those individuals, the risk of rupture, it is highest, right? And aneurysms smaller than 4 centimeters in diameter, they have low risk, right? Aneurysms smaller than 4 centimeters in diameter, they have low risk. That is, there is less than 2% chance of rupture. That is aneurysms smaller than 4 centimeters. And aneurysms exceeding 10 centimeters, they have 25% risk of rupture over 2 years. So aneurysms of 10 centimeters, there is highest chance of rupture. And current management strategies call for the identification and observation of aneurysms that are asymptomatic and sufficiently small so as not to have the high risk of rupture. So what does the current management strategies they call for? They call for identification and observation of aneurysms that are asymptomatic. So asymptomatic aneurysms, they have to be identified and observed for a long term, right? So that to avoid the risk of the rupture. And the median rate of expansion, it is slightly less than 0.5 centimeters per year, right? What is the rate of expansion? Around 0.5 centimeters per year. But in individuals with risk factors like smoking and as well as hypertension, in them the rate of expansion is slightly more, that is up to almost like 1 centimeter per year. And aneurysms that are expanding more rapidly, they are more likely to rupture than compared to that of the stable aneurysm. And patients with aneurysms larger than 6 centimeters are generally referred for surgery, right? Generally referred for surgery. Whereas the patient with aneurysms smaller than 4 centimeters, generally they have to undergo the observation. So please remember, this is a very, very important point. And what is the size of aneurysm in our patient? It is around 4 centimeters. So they don't and 4 centimeters and that too asymptomatic. So they don't require an emergency surgical procedure. But in aneurysms of 5 to 5.5 centimeters, right? Evidence of expansion, particularly if aneurysms is larger than 5 or 5.5 centimeters, is often taken as an indication to operate, right? 5 or 5.5 centimeters, it's an indication to operate. An asymptomatic patient, 4.5 centimeters in diameter, they don't require surgery, right? And it would be appropriate to assess its growth with ultrasonography over the next few years to see whether it is expanding more rapidly than compared to that of expected. And the rate of expansion is an important variable in assessing the risk of the aneurysmal rupture. So, if the rate of expansion is fast, then the risk of aneurysmal rupture is also more, right? And if the patient becomes symptomatic at any time, urgent imaging is required, right? At any point of time, if the patient becomes symptomatic, urgent imaging is appropriate. And aortography, it carries the risk of the contrast exposure, right, or of atheromatous emboli, and it offers no advantage over the ultrasonography for assessing the size of the aneurysm. So doing an aortography will not give you any added advantage. And beta blockers, they are not known to reduce the risk of rupture of the abdominal aortic aneurysm, right? It is of questionable importance. Even in the pharmacotherapy also, when I was discussing, it will reduce the hemodynamic stress, but all the studies did not prove that they will reduce the risk of rupture. Okay, so going back to the question now, so referral for surgical repair is not required because 4.5 centimeter asymptomatic, they don't require the surgery. Aortogram, the risk of contrast is there, and the treatment with beta blocker, that will not be an absolute measure of reducing the rate of expansion. So these patients, they require repeat ultrasound in 6 to 12 months. Then if you see the next question, a 53-year-old man presents for evaluation of severe chest pain. The pain has been present for 2 hours and is radiating down both the arms. He reports no previous similar episodes of the chest pain, and on examination he is diaphoretic, right? On examination he is diaphoretic. His blood pressure is 160 by 100 millimeters of mercury bilaterally, and his pulse rate is the 100 beats per minute. Chest and cardiac examinations are normal, and ECG shows sinus tachycardia but no ST segment changes. Chest X-ray is unremarkable. What would you recommend as the next step in the workup of this particular patient? So, individual with chest pain since 2 hours, radiating down both the arms, right? And the individual is diaphoretic, that means profuse sweating is there, blood pressure is 160 by 100 millimeters of mercury bilaterally, and heart rate is around 100 beats per minute. And chest and as well as cardiac examination is normal, and even ECG, there is no ST segment changes. Chest X-ray is unremarkable. What would be the next step? Aortogram, abdominal ultrasound, admission for cardiac care unit to rule out MI, transesophageal echocardiography, repeat chest X-ray. See, these particular patients, they require the transesophageal echocardiography. See, why this particular patient requires transesophageal echocardiography? First and foremost, the individual is hypertensive, and the individual has severe chest pain, and that too radiating to the arms, right? If you see the radiation radiating down both the arms. So what should be your diagnosis? It is not your MI. In case of MI, the chest pain will radiate mainly to the left arm. But in this particular individual, the pain is radiating to both the arms. So a strong suspicion of the aortic dissection, right? There should be a strong suspicion of the aortic dissection. So aortic dissection should be strongly considered, and the patient should undergo the urgent evaluation, right? The patient should undergo urgent evaluation, okay, right? So the answer is the transesophageal echocardiography. And the other point is, then you see the next clinical scenario, right? The same patient, Further testing of the patient in above question revealed that there is type B aortic dissection. He has no neurological symptoms and his renal function is normal. What would you recommend for this particular patient at this time? Heparin drip, aggressive treatment of hypertension with beta blockers, aggressive treatment of hypertension with vasodilators, surgical repair of aneurysm with Dacron prosthesis, surgical repair with endoprosthesis. See, type A dissections, they require an emergency surgical repair. But this particular patient is having type B dissection, no neurological symptoms, and renal function is also normal. So this particular patient requires aggressive treatment of hypertension with beta blockers. So emergency surgery is crucial for type A aortic dissection, but this particular patient is having type B dissection. Right? Such cases, they are managed medically by means of aggressive blood pressure control with beta blockers. And if blood pressure is not adequately controlled after beta blocker treatment, then vasodilators are added to this particular beta blockers. And vasodilators should not be used in place of the beta blockers. So beta blockers, they should be of the first important medical management. Right? And in case of type B dissection, when is the surgery indicated? See, surgery for type B dissection is indicated predominantly for patients with life-threatening complications. Right? Predominantly for patients with life-threatening complications requiring a surgical approach. Right? But our patient, no neurological symptoms. There is no kidney involvement. But when will you require the surgical intervention? That is when ischemia is there for both the kidneys. Right? And because of ischemia leading to reversible renal failure and the development of ischemic bowel or ischemia involving an extremity, those particular patients, they require the surgical intervention. But our patient, right, there is no organ involvement. So surgical intervention is not required. Right? Then you see the next question. A 67-year-old man with type 2 diabetes mellitus and long history of cigarette smoking develops severe exertional chest pain. The cardiac catheterization reveals 3-vessel disease. 24 hours later, he develops abdominal pain, pain toes and rash. On examination, he has purple discoloration of second and as well as fourth toes on his right foot and lacy rash on both the legs. Laboratory results are as follows: hemoglobin 13, hematocrit 39, WBC count 9, blood urea nitrogen 26, creatinine 1.8. What is the most likely diagnosis for this patient? Contrast nephropathy, aortic dissection, atheromatous emboli syndrome, abdominal aortic aneurysm, rupture. So, the presence of rash, right, the presence of the purple discoloration, the presence of the lacy pattern over both the legs, all these, they are suggestive of the atheromatous emboli syndrome. So this particular patient experienced the onset of the abdominal pain, purple toes. And what is this lacy rash on both the legs? That is nothing but livedo reticularis. Right? That is nothing but livedo reticularis. So all these, they have appeared shortly after undergoing the cardiac catheterization. Right? All these, they have appeared after cardiac catheterization. And these symptoms are consistent with atheromatous emboli syndrome. And our patient is also having renal insufficiency. The creatinine is 1.8, which is suggestive of acute kidney injury. And this is a common feature of your atheromatous emboli syndrome. And why not contrast nephropathy? So contrast nephropathy is common in patients with diabetes, but that condition would not account for the cutaneous finding. So in contrast nephropathy, right, you will not have the skin manifestations. And you take the abdominal aortic aneurysm or the rupture. See, the abdominal aortic aneurysm rupture, these individuals, they present with a severe hypotension. Right? And the individual will have cold, clammy skin. And they don't have this livedo reticularis. And they present with severe abdominal pain. Not chest pain, they will have severe abdominal pain. So that is the reason why your abdominal aortic aneurysm is ruled out. And even in aortic dissection also, you don't have the skin manifestations. So the answer to this question is atheromatous emboli syndrome. So mainly in atheromatous emboli syndrome, you have that skin manifestation in the form of livedo reticularis, and that usually follows the catheterization. So these are some of the clinical scenarios related to the topic of the aortic aneurysms. And in this topic of aortic aneurysms, I have discussed what are the risk factors and at what point these individuals have to undergo close surveillance of the aneurysm, at what point these particular patients, they require the surgical intervention. All that I have discussed in detail. Thank you very much.